Thank you for this opportunity to comment, Chair Khan and Assistant AG Cantor. I'm a practicing emergency physician and founder of the advocacy group Take Medicine Back. I'm here to speak on behalf of my physician colleagues who are silenced by fear of retaliation and anti-competitive contract language, often preventing them from serving patients in their own communities. Physicians are further silenced through a systematic bypassing of due process rights. Meanwhile, immigrant physicians who depend on work visas are even more vulnerable. Executives of consolidated staffing groups have climbed to the highest ranks of our specialty societies, further intimidating physicians from speaking out. My specialty, and the only de facto universal medical safety net in the United States, is at risk of collapse due to consolidation and leveraged buyouts by private equity. In the ER, I have the privilege of serving the Native American community at Cherokee Indian Hospital as a contracted physician in Western North Carolina. The only tertiary referral center for this community is HCA Mission that you just heard about, along with several smaller LifePoint hospitals. As you just heard from the two nurses unionized at these systems testify, these hospitals are severely understaffed. 223 physicians fled Mission since the HCA takeover, according to the Asheville Watchdog. Mergers and acquisitions are disproportionately harming rural and underserved communities, many of which do not have the resources to fight back. I completed my emergency medicine residency in 2017 at an Ascension Hospital, one of the most consolidated tax-exempt hospital systems in the country. When I began my residency in 2014, the ER was staffed by an independent group which was quickly acquired by a staffing firm called Team Health, the same group that, according to North Carolina corporate practice of medicine laws, illegally staffs all of the regional HCA and LifePoint hospitals in Western North Carolina. Culture shifted starkly after the acquisition to that of an assembly line, to the point where the image of a rat on a wheel became the unofficial mascot of our residency program. Corporate metrics now plague ERs across the country. Imagine being reprimanded for taking a moment to comfort a mother after the death of her child because of a failure to meet impossible metrics in an understaffed emergency department. This is the daily experience of many emergency physicians. In 2017, the year I graduated from residency, Team Health was acquired by the PE firm Blackstone. Shortly thereafter, Team Health was in the news for predatory billing practices, suing the working poor and garnishing their wages. While patients suffer, my profession's name has been tarnished. In 2019, the New York Times reported Blackstone-backed Team Health and KKR-backed Envision were behind a deceptive $28 million ad campaign by an organization calling itself Doctor-Patient Unity, opposing implementation of the No Surprises Act. Meanwhile, physicians working for Team Health and Envision have no access to what is actually billed or collected in their names. Last week, Secretary Becerra directed the Department of Health and Human Services to evaluate how providers' billing practices impact affordability of care and debt. When studying this issue, I asked the FTC, DOJ, and HHS to make an important distinction. I am not a provider. I am a physician. I took an oath to patients. Corporations did not. Please do not conflate us or refer to us with the same vague provider term whose origin hails from Nazi Germany, where it was first applied to Jewish physicians as a mechanism to demean them. The future of the emergency medicine workforce is also in peril. As deeply indebted medical students enter residency, HCA claims to be the largest supplier of graduate medical education in the United States. Documents acquired by staffing groups reveal an explicit intent to replace the expertise of board-certified emergency physicians with non-physician practitioners, increasing corporate profits while decreasing quality and expertise and placing patients at risk. This is often accomplished by charging a full physician rate even when patients are not seen by a physician, under the false pretense of supervision, a practice which we refer to as deceptive notional supervision. It quickly becomes clear that the intention of this overproduction of emergency physicians indoctrinated into the corporate milieu during their formative years is not intended to relieve a physician shortage, but rather create regional labor monopsonies. During the early stage of the pandemic, while physicians were risking their lives with inadequate personal protective equipment, Team Health cut physician hours and pay despite over $100 million in CARES Act bailouts. At the same time, increasing resentment from the public due to perceived greed of physicians has contributed to moral injury and a broad demoralization of the emergency medicine workforce. This story is not unique. It is estimated that nearly 50% of emergency physicians are now employed by a private equity-backed staffing group. United Health, the insurance company, is now the largest employer of physicians in the country. With these mergers and acquisitions in medicine, we are seeing a rapid decline in the quality of our safety net and our entire healthcare system, with a corresponding increase in costs that is simply not sustainable. Thank you.
Thank you for the opportunity to comment. I'm a physician who's practiced emergency medicine for 40 years, past president of the American Academy of Emergency Medicine. Simply put, private equity does not belong in our nation's emergency departments. The EDs where the most vulnerable patients are cared for, and it needs to be free of their profit-seeking methods. Private equity's flown under the radar to now dominate emergency medicine. The majority of states prohibit lay ownership of medical practices, specifically to keep the business influence out of the patient-physician relationship. Private equity flaunts this by setting up sham professional entities using the license of well-compensated corporate physicians. In an emergency, you may have the choice of where to go for care. When private equity owns the ED contract, the physician has no control over what you are charged. As seen with the surprise billing crisis, profits are put over patients. Hospitals have incentives to award the ED contract to private equity. This can be directly through joint ventures where collective fees are shared. In other situations, it's less need to provide subsidy. Despite having an emergency, you might not get to see a doctor because of a business decision that someone less experienced is better for the bottom line. Importantly, doctors who work for private equity have no protections when they speak up about the quality of care or patient safety. We saw ED physicians terminate that during the pandemic. The specialty of emergency medicine is in crisis. We lead in self-reported burnout at 60%. Physicians who choose emergency medicine have a strong sense of social justice. They know they will care for the homeless, those struggling with substance use, the victims of violence, weekends, holidays. Their moral code is incompatible with the profit motives of PE. They feel widely detest the role of corporations in our specialty. Many are now choosing to leave emergency medicine. Private be reined in. Thank you for your time.
Hi, my name is Dr. Vicki Norton, and I'm an emergency physician and a board member of the American Academy of Emergency Medicine. The Academy was founded in 1993 out of concern over the corporate influence in emergency departments, specifically about the quality of care and the treatment of physician employees. To this day, AAEM continues to advocate for the bedside physicians and against corporate control, which we view as putting profits over patients. Unfortunately, I've personally experienced the negative consequences of corporate ED consolidation. When I graduated residency, my first job was at an HCA hospital in Southeast Florida, where the contract to staff the emergency department was owned by two physicians. I moved across the country with a newborn daughter and bought a home in the area. I found out a month before I was to start that the two physicians had sold the contract to a corporate group called Sheridan, who in turn had a deal to staff both the radiology and the emergency departments. I was given an employment contract and told, take it or leave it. The contract had a restricted covenant and a non-interference clause. The other emergency physicians working there attempted to talk to the hospital administration to take over the contract themselves as a group and were denied, likely due to this arrangement with the bundling of staffing contracts. The quality of care at the site and the treatment of the physicians working there became so bad over the next 2 years that the entire original group of physicians who had staffed the ED for over 10 years ended up leaving, including myself. What I didn't know at the time was that HCA's entire Southeast division was under direction to contract with corporate groups, and specifically in many hospitals, to staff the ED through a joint venture with Envision. Currently, the ED in the hospital I left is staffed under this arrangement, and I've heard from colleagues that it's worse than ever working there. I luckily ended up at my current position with a physician-owned Democratic group at a nonprofit hospital in my hometown. Given the lack of jobs like this in my area, I could safely say that if my group ever loses its contract, I would either end up moving out of the state completely or leaving emergency medicine altogether, a profession I have always viewed as a calling. Thank you so much for the opportunity to speak about this.
Hi, my name is Dr. John Hopkins. I'm a residency trained board certified emergency physician, as well as a veteran of the United States Air Force. I'm deeply disturbed by the merger and acquisition activity within medicine by private equity-backed corporations such as USACS, Envision, and Team Health. I have seen firsthand how these consolidations can harm patients. As a result of these companies' commitment to their investors, profits are prioritized over patient care. Staffing of emergency departments is largely driven by the desire to maintain a significant profit margin and not on the needs of the medical staff. This directly puts patients at risk. I know this because I've worked in over 20 emergency departments throughout the United States. When I began my career in emergency medicine, I was enthusiastic and an energetic emergency physician ready to serve the public. I loved my specialty and the system in which I trained. When I experienced post-residency training was vastly different and caused me to almost abandon medicine altogether. What I discovered is the practice of emergency medicine has become consolidated to the point that corporations were able to exhibit a large amount of control over physicians' medical decisions. These corporations pressure physicians to evaluate and treat more patients per shift regardless of their level of illness, and admit them regardless of need. One very good illustration of some of these deceptive corporate practices is the Health Management Associates' massive Medicare fraud scheme, as shown on 60 Minutes. Over time, I began to despise practicing emergency medicine, a specialty I once loved, not because of the patients, but because money, not care, had become the priority. Since several large contract management groups manage all the emergency departments in my region, I could either continue in this environment or leave the specialty altogether. I decided to leave emergency medicine in 2017 due to the effects of corporate control. I was only 7 years out of residency. I miss it dearly, but would never consider going back to a corporate-rich, consolidated landscape that cares little about the patients and mainly about the almighty dollar. Thank you for your time.
Our next speaker is Salish Konda. Salish, I think you're mute.
I'm a dermatologist in Mercer at the University of Florida. I've lectured extensively on private equity and dermatology and researched as well. Dermatologists from all over share with me their disconcerting experiences with these groups. However, many of them are shackled by non-disparagement agreements and are afraid to speak publicly. Dermatology has experienced a tidal wave of consolidation over the last decade. Influential leaders in dermatology are selectively recruited by these groups in order to minimize scrutiny. There have been at least 38 regional PE-backed derm groups, 4 which are now defunct. Furthermore, 10 of the largest have formed a trade coalition, which controls approximately 70% of the PE-backed dermatology space. We're now entering a phase of regional mega mergers, and in some metro areas, consolidation is limited both choice for patients and insurers. Publications have documented a largely negative impact in DOP ownership, and surveyed physicians state these groups worsen quality of patient care and physician autonomy. Our research found some PE firms that were not performing due diligence and were employing outliers in intralesional injections performed on nursing home patients, where 75% had a diagnosis of Alzheimer's disease. Some have also acquired outliers in skin biopsies when consolidating practices. Additionally, research has shown these groups over-leverage non-physician practitioners with varying degrees of supervision, which generates larger corporate profits. The mainstream media has documented these issues, including inadequate or faulty supplies in these groups. Unfortunately, these groups are not legally obligated to disclose PE ownership to patients. Public health experts have asked legislatures for transparency and a moratorium on PE investment in dermatology. Lastly, debt valuations of these groups have decreased and many remain discounted and below pre-pandemic levels, which means if some may cease to meet their debt obligations, they will have to further increase revenue and cut costs to service large debt loads, which could further impact patient care. Meanwhile, many of these large groups tend to be small businesses, have secured over $26 million in forgivable SBA PPP loans. We hope the FTC and DOJ will also serve the best interests of patients first. The government's proposed guardrails for PE-backed nursing homes, and we now need similar vigilance for all of medicine. Thank you for the opportunity to speak to all of you today.